Okay, class, this is Lisa Peden again, picking up on that first neuro chapter and starting with the diagnostic assessment and tests that we do for the patients. The first thing we're going to do is order some lab tests, of course, or the doctor's going to order them. We're going to try and interpret them. This is going to identify any pathogen that may be causing neuro symptoms. They're going to do either a basic or a comprehensive metabolic panel. They are looking for abnormal electrolytes, abnormal glucose levels, looking for abnormal calcium, phosphorus, magnesium levels. The brain, especially the cerebral cortex, is very sensitive to, for instance, a low glucose, and so we're going to be looking to make sure the patient's electrolytes are all within normal range. They're going to be doing a CBC, and of course they're looking for an elevated white blood cell count that would indicate an infection like meningitis or encephalitis. They're going to be looking for anemia, a low RBC, hematocrit, and hemoglobin. They're going to be looking at the protein levels and lymphocyte levels. So all of these looking for perhaps malnutrition. They will be doing probably a arterial blood gas, looking for hypoxemia, because remember, the brain cells are very sensitive to decreased oxygen levels. They might do a serum drug screen where we're looking for any drug that could be causing the patient to have an abnormal neuroassessment. And then also blood cultures to see, again, if the patient is infected some way. Because remember, the blood-brain barrier protects the brain, but if that barrier is not in place for some reason, such as trauma, the patient can get a nervous system infection fairly quickly. So these are some of the labs you might anticipate. They're going to also be doing x-rays of the skull and spine first to make sure there are no bony problems. They may take several views. They might take an AP, a lateral, or an oblique view of the C-spine, maybe of the facial bones. But with any kind of head injury or multiple trauma, you must first rule out that there is no C-spine injury that could be potentially pressing the spinal cord or damaging the spinal cord. So we will be getting some just plain old x-rays, but usually several views. The next test your book covers is a cerebral angiogram or arteriogram. This is an x-ray study of the cerebral circulation. It is invasive. They will utilize contrast, which will be injected. And then sometimes that you might see an angiography or arteriography would be perhaps before a craniotomy to determine where might the aneurysm be, where might the abnormal blood vessels be, where might the tumor be, that kind of thing. They will usually use a femoral approach, but more and more it seems we are using a brachial approach. Remember the things that you must do before any contrast study. You're worried about an iodine allergy. You're worried about the patient's renal function and the contrast doing more damage. And you're also worried about metformin or glucophage, because we know that that is a drug interaction with contrast. Now, in many times this might be an emergency, and the whole metformin glucophage restriction may have to sort of be put aside. But remember all of your contrast precautions with a cerebral angiogram or arteriogram. And you can see here the kind of picture that you would get, how it shows the vessels, the contrast in the vessels. This is normal cerebral angiogram. It looks like there might be a little ballooning right here. I don't know if you can see my pointer or not, but you can see these arteriograms give very clear pictures of the vessels. Of course, they are interpreted by the radiologist, but this is what he is seeing. We talked about this a little bit. Before angiography, you want to assess their contrast risk. They do need to have a consent. They need to be NPO for 4 to 6 hours. Usually the shave and prep is done in the cath lab or in radiology. You want to be sure and assess and mark their peripheral pulses before they go. Have the patient void before they go, because they may be flat on their back for quite some time when they get back. You want to remove their dentures and hearing aids, and we may give them some kind of renal protection medications, such as Mucomist, if they have some kidney impairment, before they go, to protect their kidneys. After the angiography, you want to assess them for symptoms of altered cerebral blood flow. And again, this would just be your plain old neuro assessment, where you go into the Glasgow Coma Scale, you go into further assessment if you need to. You want to assess their groin for hematoma. They should have a pressure dressing wherever their insertion site was. Assess their feet for color, temperature, and pedal pulses. They're going to need to be on bed rest for 6 to 12 hours unless they have some kind of special closure device. So you would rely on your doctor's orders here. And you do want to push fluids with them to flush out this contrast and to protect their kidneys. And I know y'all have seen this slide before. We might also do a CT scan on the neuro patient. It provides a three-dimensional slice of a body part. The patient must lie very still. They may use contrast, but usually they start with a no contrast situation, especially if they think bleeding is present. It's non-invasive, it's painless, very sensitive. It's the test of choice in medical emergencies for almost all situations, because it's so accurate and fast. You can also do a CT angiography, which would use contrast during the CT scan to see blood vessels. So this is CT scan, again, test of choice in medical emergencies for almost all situations. Stroke, brain injury, lots of diagnoses we'll talk about. These are just some pictures of the CT scans. You can see the CT of head without contrast. You could certainly see bleeding or trauma without contrast. But if you're looking for something more specific, like tumors or infections or abscesses, you can see how the contrast will show a little more than the CTs with no contrast. We might also use MRI or MRA. MRI and MRA uses a powerful magnet. It does not use radiation, and the process by which it works is that the protons in the body act like magnets. It's a magnetic field, and these emit signals which convert to images. It's very useful for diseases caused by chemical changes within the cells, like multiple sclerosis. It's also very good for looking at structures behind other structures. It looks at soft tissue better than a CT scans. It depicts the anatomy in greater detail. So we may have MRI. You can also get a magnetic resonance angiography. This would be an MRA. And it's my understanding that they changed the software within the MRI machine, and it focuses more on the blood vessels. So it does not require the arterial stick that a traditional arteriogram or angiography would require. And y'all know what the MRIs look like, the kinds of pictures that you get. And then you can see with the MRA where they have, quote, flipped the switch, you get a better view of the blood vessels. And this is also done at the same time as the MRI using the same machine. And I hope you know that the picture on the right is showing you a picture of the circle of Willis. All right, repetitive slide again, but this is how you prepare a patient for MRI. No metal, no buttons, no snaps, no hearing aids, partials, dental partials with metal need to come out. Patient needs to be questioned about pacemakers, implants, surgical hardware, bullets. They have retained bullets. Assure the patient that it's painless, but it is loud, makes a very loud thumping, knocking sound. The patient may need to be sedated if they are claustrophobic, and we want to teach them some relaxation techniques and deep breathing techniques to help them through the MRI. Now, there are open MRI machines that can be used, but traditional MRI machines are provide clearer pictures, I've been told. So that is an option. The CT PET test is a computer-based nuclear imaging technique which has been sort of added to or merged with the CT scan in some cases. They do use a radioactive substance which is either inhaled or injected, and these particles interact with the body tissues, and it shows the brain at work. Remember, the brain is one of the most metabolically active organs. It consumes about 80% of our body's glucose. So the PET scan is going to measure the activity of this radioactive substance taking up the glucose and detecting changes in the areas where the glucose has not been utilized properly. It can measure blood flow, tissue composition, and brain metabolism. In these pictures, the red and yellow areas are the most active areas. These are the areas where the radioactivity and the glucose have sort of teamed up and is showing the brain using that tissue effectively. It is becoming more widely available. We used to have a traveling PET machine. It was only here on one day and that kind of thing, but most hospitals of any size now do have a CT PET machine. There is somewhat of a patient preparation for a CT PET. The patient is told they can have no caffeine, alcohol, or tobacco for 24 hours prior to the test. They should then also be NPO for 6 to 12 hours. They want them to avoid IVs with glucose. Again, we're looking at the patient's normal glucose metabolism in the brain, so we don't want them to have any excess glucose. They should have no sedatives prior to the CT PET, and they should have no diabetic medications before a PET, because again, the general principle of this procedure is to see how the patient is utilizing the glucose in their brain. Now I will show you that, or I'll tell you that the picture on the left is a normal CT PET, and you can see that symmetrical areas of the brain have taken up the radioactive material, and the yellow and red areas are areas of great activity in the brain. The picture on the right is a picture of an Alzheimer's patient, and you can see that there are large areas of the brain where the tissue is not responding correctly to the radioactive nucleotides. So that's just an example of a picture that you might get. Some of the common diagnoses that you would see CT PETs ordered would be things like Alzheimer's, brain tumors, stroke, mental illness, dementia, epilepsy, and cancer. Okay, so very sophisticated, but being used more and more. And this is a normal PET scan, CT PET of a 20-year-old. See, the red and yellow areas are very active, and they have similar patterns on both sides of the brain. This is a CT PET of the brain of a very intelligent physicist. So the red and yellow areas are most active, so this just shows a very active normal brain. Okay, now we're going to talk about SPECT scans. These are three-dimensional scans where they have cameras that sort of spin around above the patient. It also utilizes radionuclides and a microcomputer to get these images. It allows areas behind other structures to be viewed. There is a great contrast between normal and abnormal tissue, which you can see in this picture. It is used for processes such as stroke, seizures, and assessment of perfusion before and after neurosurgery. Now, it is contraindicated in breastfeeding and pregnancy. We have actually been doing SPECT scans longer than we have been doing PET scans. And what I have read and what I have copied to your notes is that actually SPECT scans are cheaper than PET scans. So this is a picture that is showing mild to moderate perfusion deficits involving various regions of the cerebral cortex. And you can see, again, red and yellow are areas of very high activity or normal activity, and then there are areas in the frontal cortex here where there's not a lot of activity. So these are some just SPECT scans that I saw as I was researching this a little bit. This is a stroke, so you can see that the dark areas are parts of the brain that are not working well. Look at this depression scan where the whole sort of, I think that's sort of a side view of the brain, and the whole frontal area is not really got a lot of activity. And then chronic fatigue syndrome. you can see there's areas there that are not working very well. So I think this is fascinating. I liked reading about it, and I won't share a whole lot more detail about that, but they are becoming more popular and more available. Okay, the EMG is electromyography. This is a procedure that is usually done in a special testing lab where small needles or probes are injected into the skeletal muscles, and then they measure any changes in the electrical potential that they see when they send a small impulse through these needles. It's useful in detecting neuromuscular disorders and myopathy. So those patients who come in with weakness, or patients who have ALS or muscular dystrophy or myasthenia gravis, maybe trying to rule out some of those disease processes, but commonly done on patients who are admitted with a diagnosis of weakness. Now, after a patient has a EMG, they will have some achy muscles after this. They will feel like they've exercised a lot because the stimulus running through these probes has basically exercised their muscle. So they may have some achiness after the procedure. And one question that is commonly asked is, what kind of medications would you withhold from the patient before they have an EMG? And the correct answer would be muscle relaxants such as Flexeril, Xanaflex, the benzos, Valium, because that would obviously skew the results of your EMG. All right, this is an EEG, electroencephalogram. It records electrical activity in the brain. Electrodes, usually 16 to 24 of them, are applied on the patient's scalp. A baseline recording is taken where the patient lies very quietly with their eyes closed, and then a reading of the patient's brain waves occur on the monitor or on the paper. It can be printed. We do sometimes do these during sleep, where we have given the patient a sedative and then record their EEGs during sleep. This would be like a patient who only had seizures at night. We would want to see what happens during their brain while they're asleep to see if there's something that is occurring making their seizures. They may also want to do sleep-deprived EEGs where the patient is kept awake. We also do continuous EEG monitoring where they may do it 24, 48, 72 hours continuously. And again, it's used for patients with seizure disorders or sleep disorders, or patients that just are having unusual activity. They may want to make sure that they are not having a seizure that is not classic. We want to tell them before a EEG to avoid caffeine, avoid stimulants, and depressants. We don't want them to fast because hypoglycemia or low blood sugar could cause a change in their brain activity and cause abnormal test results. So I've got a picture of a baby here having one. I can't imagine how hard it is to keep all of those probes on a baby. Adults will tell you that they have to shampoo their hair several times after they finish with one of these, because there's a lot of goop and conductive gel and that kind of thing left in place. But this is a EEG. Okay, evoked potentials studies are used to assess sensory nerve problems like multiple sclerosis, brain tumors, brain activity while a patient's in a coma. They want to measure the electrical signals to the brain that we can invoke, such as visual symptoms, auditory symptoms, peripheral somatosensory skin stimulus. So first, the electrical electrodes are attached to the scalp. The second set of electrodes are attached to the body part that's being tested. And then it measures the time from the stimulus to the time the impulse takes to create a muscle reaction. So in the visual evoked potentials, which is the picture you're seeing here, the patient looks at a visual stimulus like a flashing light or a checkerboard pattern, and they monitor how long it takes her to have a reaction to that. With auditory, they use a repetitive auditory click in a soundproof room. The patient would have on headphones and would hear a clicking sound in each ear, and they are looking for what that evoked in the patient as far as muscle movement, peripheral movement. For a peripheral somatosensory test, they would use an electrical stimulus through the skin, much like they do the EMG, to test the extremities. So evoked potentials can be visual, auditory, or somatosensory, or peripheral, and we are applying some other kind of stimulus to the patient to see if we get a response. The lumbar puncture is probably the most invasive neurotest we do besides an arteriogram. This involves inserting a needle into the subarachnoid space of the spine, somewhere around L3, 4, or 5. Remember, the spinal cord ends at L1, and so that's why we go below that point for a lumbar puncture or a spinal tap, which is the lay term for LP. We also know that there is a large collection of spinal fluid below L3, and so we have a better chance of getting spinal fluid at that level. It's useful to obtain a cerebrospinal fluid sample for examination or to diagnose a problem. We also can measure the pressure of the spinal fluid and drain spinal fluid if we need to, if the patient has a elevated pressure. We can determine the presence of blood in the cerebrospinal fluid, which would be abnormal. Spinal fluid is very clear, crystal clear, normally. If we needed to administer antibiotics straight into the cerebrospinal fluid, such as for encephalitis or meningitis, we could do that during a lumbar puncture. And finally, if we need to administer anesthetics or analgesics to block sensations, like for surgery, for pain control, for childbirth, we can give those kind of medications during a lumbar puncture. Some of the diagnoses you might see a lumbar puncture ordered would be multiple sclerosis, meningitis, cancer, and they would take a small amount of fluid and analyze that and be able to sometimes provide a diagnosis. This is the position the patient will be asked or assisted into for a lumbar puncture. It's the lateral recumbent fetal sideline position. One source called it a cannonball position, but the patient is on his side with his knees drawn up to his chest and his head flexed. This hopefully opens up the space between the vertebra and provides the physician with a wider area for getting the needle in. Now, I have also seen lumbar punctures done with the patient sitting on the side of the bed and hunched over a bedside table. So that would be an alternate position. This procedure is a consented procedure. The patient may have a small pillow under their head, but we need to be sure and help them, hold them, or keep them from having any sudden movement during the LP. If the patient has got a cough, we would want to give cough medicine. If they're sneezing, we need to alert the doctor of that. But anything like that could potentially be dangerous while the doctor is trying to get that needle in. The doctor will collect 3 to 5 tubes of cerebrospinal fluid, and these will be taken to the lab, and they will analyze them for cell count. They will do a culture on those. They will analyze glucose levels and protein levels, and this is part of how the diagnosis is made. This is a video. I will show this in class, but for some of y'all that are at home, this is a real good 3-minute video that shows a lumbar puncture, so I encourage y'all to watch that. Okay. And these are bottles of cerebrospinal fluid. The A bottle is normal. It is clear, colorless, thin, and this is what spinal fluid should look like. In B, C, and D, there is blood in the spinal cord. In C and D, the blood cells have just settled down to the bottom, and that's plasma above these, but these would all be positive for blood. Just some tips about analysis of these spinal fluid samples. In the lab, if the WBC level is elevated in the spinal fluid, obviously this would mean that the patient has an infection or a meningitis. If the protein is elevated, that tends more toward a viral infection rather than a bacterial infection. And if the glucose in the spinal fluid during the analysis in the lab is low, that indicates a bacterial infection. And I can always remember that because if you think about what bacteria like to eat, they like to eat glucose or sugar. So if the sugar level in the spinal fluid is very low, then there's a good possibility that the patient has a bacterial infection. So those are just some tips. I believe there's a chart in your book that tries to sort of summarize the results of a spinal fluid analysis. After a lumbar puncture, you want to encourage fluids. You want to replace the fluids by mouth or by IV that the patient has lost during the LP. They do need to be on bed rest for 2 to 3 hours, and they need to be flat without an elevation in their head. We know that about 25% of patients will get a post-lumbar puncture headache, and this headache may range from very mild to very severe, and it may appear a few hours or several days after the lumbar puncture. Patients describe this headache as a throbbing headache, bifrontal or occipital. It's very dull and deep in character, and it's more severe with the patient sitting or standing. So this is caused by a leakage of cerebrospinal fluid at the puncture site. So again, patients need to be flat in the bed on bed rest for at least 2 to 3 hours. If they have a headache, we can give them analgesics, and hydration will help. If the patient continues to have this persistent headache, they will have a blood patch. This means that blood is taken from the patient's vein, from his antecubital vein, peripheral vein, and this blood is then injected into the epidural space or the subarachnoid space at the site of the spinal puncture. And of course, this would be a doctor procedure. This might be done in same-day surgery or in a special procedure room. Patients will tell you that as soon as the blood patch is injected over that area and seals the leak, they have immediate relief from their pain. But again, this would be done for those with persistent headaches. And the last test this chapter covers is called a transcranial Doppler study. It is an ultrasound, basically. It is non-invasive. It uses ultrasound over the temporal bone. If you remember where the temporal bone is, it's way up here around your eyes. This bone is very thin, so you can actually Doppler or ultrasound through this bone. It's helpful for assessing for vasospasm after a subarachnoid hemorrhage. It can be performed at the bedside. It's relatively low risk and not very expensive, so you might see a transcranial Doppler study in the patient's room or perhaps in x-ray. All right, that ends my part 2 lecture over neuro assessment. Thank you.